Assalamu alaikum. I'm Junaid Paikar, Chief Coordinator, National Liver Foundation of Bangladesh. I'd like to welcome you all to our webinar on World Hepatitis Day 2021, organized by National Liver Foundation of Bangladesh. First, I'd like to introduce with our speakers through slides. I'd like to introduce Dr. Wang, President, World Hepatitis Alliance, Professor Manal El-Sayed, Professor of Pediatrics, Director of the Faculty of Medicine, Ain Somt University, Egypt, and she's also founding member of the Egyptian National Committee for Control of Viral Hepatitis. Professor R.P. Shanmugam, Regional Board Member, Southeast Asia Region World Hepatitis Alliance, and founder, Chennai Liver Foundation. Professor Muhammad Ali, founder, National Liver Foundation of Bangladesh. Professor Salimur Rohman, President, Association of the Study of the Liver Disease, Bangladesh, former Professor of Hepatology, Bangabandhu Sheikh Mujib Medical University. Professor M. Anisur Rohman, Joint Secretary General, National Liver Foundation of Bangladesh, former Head, Department of Gastroenterology, Burdem General Hospital. Professor Dr. Fauque Ahmed, General Secretary, Bangladesh Gastroenterology Society, Director, Sheikh Russell National Gastro-Liver Institute and Hospital, and Professor Dr. M.D. Shahinul Alam, Secretary General, Hepatology Society, Dhaka, Bangladesh, and Professor, Department of Hepatology, Bangabandhu Sheikh Mujib Medical University. Before I start today's conversation, I'd like to give you an overview of our activities of the Liver Foundation. So, in this World Hepatitis 21, in this special webinar, Hepatitis Can't Wait, Bangladesh, and I'm Junaid Moshe Paikar, Chief Coordinator of Bangladesh. I want to share our activities of the Liver Foundation. First of all, I'd like to mention you that this is a very special year for us. We are celebrating 50 years of Bangladesh. All the heroes who have contribution in our independence, I want to remember them all. Now, I'd like to share that in Liver Foundation, we are actually, our working areas is awareness, testing, vaccination, treatment, and advocacy. In awareness part, as you know, we are working with the World Hepatitis Alliance since its inception. And from 2008 till today, we are organized Hepatitis Days. You can see these images of 2008, 9, 10, 11, 12, 13, 14, 15, 16. Every year, we are actually try to organize different activities with youth participation with different manners. And then we have a No Hep campaign. We drive throughout the country when we touched 8 divisional headquarters and aware students and teachers everywhere, and also meet with the legislators and all these 8 divisions. So this is a 11-day campaign. Then we do a No Hep network where some volunteers around the country worked with us to promote the No Hep awareness messages to their educational institutions. We have, you know, cricket is very popular in Bangladesh, so we actually are targeting the cricket-loving community. So we introduced No Hep cricket. Through it, we actually aware cricket-loving youths of Bangladesh. In everywhere, we are arranging this sort of cricket events. Recently, from Southeast Asia, we are selected to doing a project with Alliance in the Find the Missing Millions campaign. And this is one campaign we worked in the Rangamati area with the indigenous community. We aware them and screen them as well. And then it's another program which is we screened thousands of students throughout these years, which is one of the main concern to testing university students, school students. So this is the last program, what you are seeing here before the pandemic. We work with students from different parts of the country. Then we also, you know, Rohingya refugees, a big problem for Bangladesh, not only for Bangladesh, and the world is concerned about it. And you know, the Rohingya, they are not that much aware about diseases, so we screen them. 2,000 plus we screened their hepatitis B and C, and the result is very alarming. So we do a screening there a few years ago. Then we have vaccination program. We already vaccinated 6,000 plus orphan children, those who stayed in the government children home throughout our country. Then in treatment part, we have a Zakat Fund where we treat underprivileged BNC patients, those who can't afford to treat. So this is also an ongoing program. We already treat 153 patients, and this year we included another 70 patients. And now we are in lockdown. So after lockdown, we will continue the project with them. And we also organize patient conference with BNC patients. As you know, there is many patients in Bangladesh, but the hepatologists and gastroenterologists very limited. So we organize this sort of patient conference where patients actually ask their questions and take guidelines what to do and how to do these things. And it's a very effective program. We do several conferences like that. We started it from 2012. So we in treatment part, we also have consultation centers in Dhaka. We do consultation of BNC patients. And in lockdown, we also do online consultations for patients who didn't come because of the lockdowns and the restriction of COVID. So we also run these online consultations in our center. And advocacy part, we do roundtables with people who can make changes. So we invited them and talk about hepatitis B and see what to do and what is the present situation. And we have several roundtables. And we also, in Hepatitis Day events, we also include ministers, people from WHO, from Health Ministry, to engage them and to brief them about the present situation and what changes we should do. And you know, before the COVID in 2019, we invited the Chief Justice of our country in our program. But in the last 2 years, because of COVID, we can't do outdoor events. You know, our Professor Muhammad Ali meets ministers and secretaries, and we also conduct a program with all the divisional commissioners and district commissioners. We give them letters about the situation and urge them to do something and to do awareness in their areas. So we are also conducting these things. And this year, in 2021, as you know, it's a lockdown and COVID situation, but we are trying to do some programs. We already make some merchandise, t-shirts, and can't wait clock because it's related to a time. So we make a clock and also mask to aware people and also save from COVID. This year, we will publish the official souvenir of World Hepatitis Day 2021. It will be our 14th edition. In this souvenir, there will be a message from Honorable President, the People's Republic of Bangladesh, Honorable Prime Minister of the Government of the People's Republic of Bangladesh, and Minister of Health and Family Welfare, Government of the People's Republic of Bangladesh, Director General of Health Services, DGHS, and President of World Hepatitis Alliance. There will be also articles on viral hepatitis. And we also take help from our cricket portal, Cricket 97, where we post our ads of Hepatitis Day information on their website throughout this month. And then we have a program of mother-to-child transmission. In last year, our President Wang emphasized on this issue. So we make up brochures of Bangla and English both. And we plan to do a webinar on mothers to child, and we want to include the gynecologist of our country to this program. I think we'll do it in end of this month. And the good news is we engage Bangladesh Medical Student Society with us this year. And with them, we want to aware the medical students about hepatitis B and C. So we already have a Youth Can't Wait Bangladesh webinar with them. And we also make posters for them. We already distributed. Some of them already get it, and they will distribute it in their institutions for awareness. And we have a very good news just before the World Hepatitis Day. Our founder, Professor Muhammad Ali, got Hepatitis Elimination Champion 2021 award from Coalition for Global Hepatitis Elimination. We are really proud that Professor Ali got this award. And another good news is our very own Charles Gore, the founder president of World Hepatitis Alliance, also send a message to Professor Ali with very kind words, and we really happy to have it. Okay, thank you all. Now I'd like to request Professor Shahinul Alam sir to talk on these topics.
Can you hear me?
Yes, okay, it's okay now.
Okay, good evening to everybody. It's a great honor and privilege for me for the occasion of World Hepatitis Day 2021. I must thank to Professor Muhammad Ali to give me the opportunity to talk on this occasion. My talk is on diagnosis of hepatitis B and hepatitis C in Bangladesh, barrier to achieve elimination by 2030 goal in COVID pandemic. During the COVID-19, total health system is exhausted in Bangladesh as like other countries where we are confronting the third wave of the COVID-19. Bangladesh is a middle-income country with 160 million population with shortage of health workforce and logistics and budget also. But Bangladesh has got the very good history of successful EPI program with 95% coverage of newborn, and that includes the hepatitis B vaccination. Our country contains 10 million patients of hepatitis B and hepatitis C virus. Out of them, 8.5 million are hepatitis B and 5.7 million of them, 5.7 million are male and 2.8 million are female. 400,000 children and female of childbearing age of 1.8 million people are carrying the hepatitis B virus. In Bangladesh, the prevalence of hepatitis B virus is gradually decreasing from around 10% to presently at 4 to 5%. So we are in the right way to eliminate the hepatitis B virus by 2030. But in the recent years, the hepatitis C virus is increasing from the previous prevalence. The patient of hepatitis B and hepatitis C virus are diagnosed during the medical screening for the worker who are intended to go abroad. Otherwise, there is no national program for screening test for these viruses. People are tested who are coming to access the health facilities, and which is only 30% of the total population. The accessibility and acceptability of the health system is increasing progressively in our country. During the COVID-19, all the facilities are limited, so the diagnosis is reduced and the EPI program is also interrupted. So it is very challenging to achieve the target of elimination of hepatitis B by reducing the new cases. To overcome the situation, re-strengthening of the EPI program may be an option, and especially the target group, especially the childbearing lady and the child, preferably maybe selectively could be screened for the hepatitis B virus and hepatitis C virus, especially for hepatitis B virus. And hepatitis B virus testing, the screening test, that is HBsAg and anti-HCV testing, may be recommended as free of cost for everybody and everywhere. Not only the government organization, non-government organizations, social workers may uplift the canvas to screening of the hepatitis B and hepatitis C virus, may progress the detection of hepatitis B and C virus, and we may achieve the goal of elimination of hepatitis C and B virus in 2030. Thank you all. Thank you, everybody.
Thank you, sir. Thank you for your speech. Now I request Professor Salimur Rohman, sir.
Thank you for inviting me to give a talk on the treatment of hepatitis B and C and its barrier in Bangladesh. First of all, I'd like to thank National Liver Foundation and its key person, Professor Muhammad Ali, and the other distinguished office bearers for inviting me to participate in this very important and auspicious webinar. And I also thank the President of World Hepatitis Alliance and other distinguished guests for giving their valuable time in participating in this webinar. And all of you know that hepatitis B and C is very much prevalent in Bangladesh. As my previous speaker has already said, that the prevalence of hepatitis B in Bangladesh has come down, and it is approximately 5 to 6%. And the hepatitis C is about 1%, and this has been found in some recent investigations. Both of them are very important for Bangladesh, and all of us, we know that though hepatitis B is much more prevalent in Bangladesh, but treatment of hepatitis C is also very important because most of the hepatitis C patient becomes carrier and needs treatment. So let us first, our main problem is hepatitis B, and though hepatitis C is also very important. Let us first discuss about the treatment facilities available in this country about hepatitis B. We will all happy to know that all the modalities of treatment is available in Bangladesh, and especially in a very affordable price, because the generics are available in Bangladesh and we frequently use these generics, and these are much, much less costly than available in Western countries and developed countries. The drugs available in Bangladesh are interferon, lamivudine, adifovir, entecavir, telbuvudine, tenofovir, diproxil, and tenofovir alafenamide. All these are available, and you must be happy that these are available at much lesser price than the Western countries. We previously used to use interferon mostly, but nowadays we use the oral drugs, and especially the maximum we use entecavir. And if you say what is next, I can say that tenofovir and diproxil and tenofovir alafenamide is in the next serial. But all the drugs are available, and it is used by all the specialists in this country. Interferon we use less because people are very reluctant to take the injection, and its course, its side effects do not allow us to use very frequently. But people prefer the oral drugs, and these drugs are very easily available. Now, let us come in short about the treatment facilities available for hepatitis C. As I have already said, the percentage is less prevalent, but as the majority becomes chronic, so treatment burden is not very less than hepatitis B. And all the drugs, I should not be all the drugs, the most important drugs is also available in Bangladesh and at a very affordable price. Drugs available are interferon, ribavirin, direct-acting antivirals, DAS, and among them sofosbuvir plus velpatasvir combination drug, sofosbuvir plus ledipasvir, and sofosbuvir plus daclazazvir. The newer drugs, voxilapravir and glicapravir and pibrentasvir was not available. Other drugs are available easily, but very, very recently, glicapravir and pibrentasvir has been available in the market for use. So I should say that for treatment of hepatitis B and C, we have in our hands all the available treatment, which is also available in Western countries. But the very rare DAS, other DAS is not available, and we hope that we'll soon get these drugs in an affordable price, especially in generic form. And if I come to discuss about the barriers of this treatment, and first I should say that education and awareness is the most important barrier. Next is the economic barrier. The poor economic condition of the patient is an important factor, and the cost of the drug is also important. Though I have said it is affordable, but as our people are very poor, this affordable price is also they cannot afford sometimes. So I think the government should come up and give subsidy give subsidy so that the people can afford the drugs to treat themselves. And I have seen that recently government, to achieve the SDG goal, government have given in many big hospitals the treatment of hepatitis, the drugs for hepatitis B and hepatitis C at free of cost. And I also think that the insurance facilities in Bangladesh should be available, which is also a barrier. And if insurance facilities are available, then people can afford to treat themselves. Help from the international organization and also NGOs can also help our people to get the treatment. And the cost and availability of the treatment diagnosis facility should also be available to ease the treatment for the poorer people of the country at an affordable price. And you all know that COVID is COVID-19 is pandemic all over the world, and we are in a very abnormal situation. So the program of elimination of hepatitis B and C by 2030 has become a challenge, and our government is trying to compromise between to balance between the life and the economy, and government, I think, in the right path, and government is trying hard to achieve this goal. Thank you all. Thank you for your patience here.
Junaid, please unmute.
Absolutely. Thank you, sir. Thank you for your very informative speech. Now I like to request Professor Anisur Rohman, sir, to say his presentation speech. Sir, to unmute corner.
Sunajai, can you hear me?
Yes.
Oh, thank you. Thank you, Professor Muhammad Ali and our team to arrange this webinar, this important webinar in the eve of World Hepatitis Day. This year, the theme of the World Hepatitis Day is the no hep, and hep we cannot wait anymore. So this is the theme of 2021, and the goal within 2030 is to reduce the most burden of the chronic hepatitis B and C, so that the at least 10 lives of 10 million people can be saved by reducing the hepatitis B and C burden in the whole world. All of you know that throughout the world, the number of chronic hepatitis B and C is about more than 325 million. And so it's a very vast number. And among these, the most strategic point is this: to detect them and treat them adequately is the main goal. And of course, the prevention is the motto of this, to remove the burden of this chronic hepatitis B and C. So if we come to our country, the situation, ours is a small country, but about 170 million people, and it's a very highly densely populated area. So the more common problem is hepatitis is the hepatitis B than C. For prevention strategy for the hepatitis B, so previous speakers has already said that about our national, there are different studies. So in recent studies, it has been found that it is decreasing. The hepatitis B number is decreasing. About many studies, they said 4 to 5% of the populations are suffering from hepatitis B. Previously, it was up to about 7% in some stages. The most common causes of this chronic B hepatitis in our country, I think, is possibly due to this vertical transmission from the pregnant ladies to the mother to the babies, and that is the main cause of this chronic hepatitis. And few cases, the caregivers by the caregivers to the small kids or babies during their or after birth. So our main target of population to control the hepatitis B should be first, as Junaid has already mentioned, that we have to work with the gynecologist, that we have to target the pregnant ladies. In urban areas, it is very easy to screen the, because most of the gynecologists and others, physicians, pregnant ladies, they usually screen their patients for hepatitis B invariably. But the situation is a bit different in the rural areas, because there is not all areas the facilities are not available. But we have a good infrastructure for the health facilities. We have rural health center, and we have thousands of these community health clinics. So we can take their health, and also we have thousands of health welfare workers. They are responsible for mother and child care and their nutrition and health. So they can be utilized. They can be utilized very easily. They usually visit door to door, and they know who are the pregnant, and they can be brought to the nearby clinics or nearby hospitals for the screening, because the screening test, especially SBSAZ, is almost available in all Thana levels. So that is one thing. But for treatment purpose, they have to go for in the city for treatment. But at least the screening is a good thing, because you can take the adequate precaution for their child incoming child, because if they found positive, the mothers will be intimated that your child should be vaccinated immediately after the birth. That is the on goal. We should advocate very loudly and very adequately to our government authorities, the NGOs who are working with the health and welfare of the mothers and child, and other social workers also. And then subsequently, we should the vaccination have already been mentioned. EPI program. We have a very good EPI program schedule in our country, but due to this, due to the recent COVID situation, already it is, I think, it is hampered. But the one thing, it was incorporated. The vaccine was incorporated with the vaccine of the child in the 6 weeks of the after birth. So we, Professor Muhammad Ali and we, and Muhammad Ali sir also sat with the health minister and also the line directors of the immunization program, and they agreed to give the child the birth dose of the hepatitis B vaccine. But I think it's not yet implemented. But that will be immense important for a country like us, where hepatitis B is still chronic hepatitis B is still very high. So that is one thing for the hepatitis B. And for the adults population, we should screen, and for any health care facilities they come, or for the health reasons they come, we should screen them. And if you found them positive, we should adequately test them, and then if needed, we should treat them, because hepatitis B is not curable, but it is treatable. So we should be careful, and we should take precaution for this population and take care of them. About the hepatitis C, unlike hepatitis B in our country, hepatitis C is not very much prevalent, and number of hepatitis C also is coming down, because some studies they have found that only 0.3% to up to 1% of the population are suffering from hepatitis C. And already Professor Salimur Rohman has already said that all the drugs are available for treating the hepatitis C. But the problem is though it is generic and drugs are available with much less cost than the Western world, but still for the general population it is still costly. So in some government institutes and hospitals, government is supplying this free of cost. I think it should be available to more facilities, more medical colleges, hospitals like that, so that general population can access for these drugs. And for the we have to go for the screening for whom we should screen. For all adult population, once in life they should screen for hepatitis C. And for a special group, we have some special groups such as thalassemia, then this hemophilia, then other blood disorders, then hemodialysis patients. These are the groups of patients who get repeated transfusion. And for the blood transfusion, we should meticulously screen the hepatitis B and C, and we should transfuse them. And this group of patients, the incidence of hepatitis C is very high in comparison to general population. In some cases, maybe up to 20% of the dialysis patients sometimes have the hepatitis C. So we have to periodically check up this group of populations who get repeated transfusion, so that we can treat them timely, so that they cannot develop to a chronic liver disease or cirrhosis. And another group, the IV drug users, then they are very notorious there, because the incidence of hepatitis C virus is also very high in this group of population. So we have to target them also for screening hepatitis C and treat them accordingly. So dear colleagues, today we are honored by President of World Hepatitis Alliance, and also the guest from Egypt, Manal El-Sayed. These are the situation in our country, and we are with the leadership of Professor Muhammad Ali, we are trying to help our population for giving service, awareness, and giving them treatment as far as possible, as we could give them some help. So, and during many of the program have been hampered to this COVID situation, because the situation was not much bad last year, but this year it is worse, we can say, especially last 2 months. The situation is very worse, especially the rural area. It was almost free from the COVID in last year. Only sporadic cases were reported from the village areas. But this year, the situation is different, because the COVID situation now is equally prevalent in city areas and in the rural areas. Rather, the rural areas, people are suffering more because they have less testing, so the reports are being less. So many of the programs, other health care programs, are being hampered due to this COVID situation. So hope this situation will not exist long. We'll overcome this situation, and we'll help our people to overcome these hepatitis B problems soon. So thank you very much. Thank you again.
Thank you, sir. Thank you. Very elaborately discussed the situation. Now I'd like to request Professor Fauque Ahmed, sir, to deliver his speech.
Thank you, Mr. Jonas Paikar. First of all, I want to give my heartfelt thanks to Professor Muhammad Ali and his team for inviting me in his all meetings. And this is a special opportunity also this time for me to speak in a meeting where President of World Hepatitis Alliance, Wang is here. So it's really a great pleasure for me to speak in this meeting. And as I have to talk on prevention of transmission from mother to child, and at the outset, I want to tell that everybody of us know that hepatitis B is a big burden disease. big burden disease in the sense that it is prevalent worldwide and prevalent with impressive frequencies in many countries, and it is also a costly disease. So we have to be very careful about it. And if we talk on hepatitis B, I think nothing good for hepatitis B we can talk. Only the good thing for hepatitis B is that it is preventable. So as it is preventable, that's why WHO has set up the goal to eliminate these viruses by 2030. And this is a good thing in favor of hepatitis B management in the world. So as WHO has fixed up the target to eliminate this hepatitis B by 2030, so we have to adopt all out efforts to eliminate it by whatever the steps we now we know about it. So as the disease is very prevalent in many parts of the world, and is also very prevalent in Bangladesh, and fortunately over the last couple of years, the frequency of hepatitis B is declining. And recently we had a study at the community level in the rural areas, and we have covered a lot of people in that study, and that study found a frequency of about 3.5% in the rural communities, which shows a figure much lower than the figure that was quoted previously. It was 7 to 8% in the previous study. So it is a good figure for us to see that the hepatitis virus is possibly declining in our country, and it is declining because of a lot of factors which all of us know. So as it is preventable, we have to go for prevention to everybody. And if we talk about the prevention, definitely the prevention of hepatitis B virus transmission from mother to baby is very important area which we have to think with special attention, because this group of people, that is infection that is occurred in in infants, newborn babies, these are the infections which will last longer and go for chronicity and will develop a lot of complications like cirrhosis liver and hepatocellular carcinoma in the long run. So these are the special group of people for which we have to be very careful. So we have to give special attention to our female population, and we have to be very careful about the prevention of this infection in the female community. So if we talk about the prevention, definitely that it is of two steps, like primary prevention and secondary or tertiary prevention. So we have to target our female population for primary prevention, and we have to target them to vaccinate whenever we can catch them. So female population, we have to attend with special attention to vaccinate them as early as possible with hepatitis B virus vaccine, which is widely available in our country right now. So this is one area. If anybody for some reason is not covered with vaccines, and if she is pregnant, in that cases, we have to fix up a target to bring them as early as possible to medical attention, and to bring them for hepatitis B virus serological test. And as soon as they are found to be positive, definitely they are the highest mother to transmit these viruses to their babies. And then we have to also test, if possible, it will be DNA or SBEAG if DNA is not available, so that we can also have a idea about the status of this infectivity of these viruses. And if anybody is SBEAG positive or DNA positive, definitely these mothers are will transmit this infection with more and more frequencies to their babies. So we have to do this test in all pregnant ladies. And if they're found to be negative for SBCG, definitely we have to go for vaccination. So they should bring under vaccination strategies, and they should be vaccinated as usual as other people. And if they are positive for or if they are positive for HPV DNA, in that case, definitely we have to bring them for treatment, because as the previous speakers are telling, that all the drugs available for the treatment of hepatitis B virus in other countries, these are also available in Bangladesh. So we have to go for treatment of this infection in the pregnant ladies. And by treating them effectively, definitely we can be able to prevent the transmission of the virus to their babies. So this is the important area for which we have to think. But unfortunately, in our country, we do not have any national policies to bring these pregnant ladies under a specific schedule. But with the build-up of increasing awareness among the population, including the mother, and with the expansion of our healthcare services to grassroots level, now majority of our populations are under healthcare coverage. So more and more ladies are now under medical attention, and more ladies are now undergoing screening for SBSAG, and more ladies are now under coverage of vaccination. This is a good thing for us, but we can advocate our policymakers to formulate a national policy to bring all of them under medical attention and attention for hepatitis B virus screening and vaccination. This is important area. And second thing is that to prevent this infection in the children, definitely in our country, we do have this immunoglobulin and active vaccination. But unfortunately, in our country, we could not go for at birth vaccination. Right now, we have a coverage of vaccination to the infants at the age of 1.5 months, and that has been included in the EPI. This is also good for us because in our country previously, government was not taking these steps to cover those infants. But from 2003 to 5, government has included hepatitis B virus vaccine in EPI schedule. And for this, nowadays, almost all the newborn babies in Bangladesh are now under coverage of EPI. So almost all the newborn babies are now getting hepatitis B virus infection. Only thing is that they are getting this vaccine at the age of 1.5 months. And our target now is to start this vaccine at birth. So this is one challenges which we have to face, and we have to work on these challenges to start at birth dose vaccine for all our infants. And fortunately, these are available at free of cost, and these are all been provided by the government even to the remotest area of the country. This is a good thing, and for which for this successful vaccination and this wide coverage of vaccination to almost all infants, all newborns in the country, our Honorable Prime Minister has been awarded with Vaccine Hero Award from the world community. This is an outstanding performance of vaccination, which is an example for other countries. And this is also a very effective steps for prevention of transmission of viruses to most of our infants. And that's why hopefully the prevalence of this virus infection is now declining even in our country. And last of all, I want to tell that the increasing awareness, most of the ladies are now they know that hepatitis B virus infection, which she could transmit it to her babies. So she has to go for screening, she has to go for treatment, she has to go for vaccination. So this awareness has been built up, and I should say that this awareness build up credit will go also to the credit of Professor Muhammad Ali, and he's doing a lot of things to build up this awareness. And along with this awareness, I hope we have to go also to educate our people. People now knows almost every people I hope knows about SBP, and we have to go for more and more education to the people so that most of the people will come spontaneously, come to the health system coverage for screening and for effective vaccination. And if they are positive, in that case, they will come for treatment. And with this thing, possibly we could be able to eliminate the transmission effectively to the children from mother. And we have to advocate our policymakers to start this vaccine to the infant at birth. And with this thing, I hope, like Taiwan, we could be able to reduce the level of this prevalence of viruses to an acceptable level for with which we can demand the elimination of this virus by 2030 even from our country. That's all from my side. Thank you very much for giving me this opportunity to speak in front of you. Thank you very much.
Thank you, Professor Fauque Ahmed, sir, for your speech. Now it's time for Professor R.P. Shanmugam, but I think his Zoom is not working well. Sir, are you hearing us? I think he's there, but not actually hearing us. So I think it's not here. So now I'd like to request Professor Manal El-Sayed to say a few words about his journey in Egypt's elimination programs.
So can I share my screen?
Oh, sure, ma'am.
Okay, so I'll be very brief. I'll just touch on our program first. I would like to thank Professor Muhammad Ali for his kind invitation, and congratulations for being the champion this year. I've seen that you've done some excellent work. Really, the Liver Foundation has been doing some great work, and I think in collaboration also with the World Hepatitis Alliance, and a lot of awareness campaigns that actually worked wonderfully well in Egypt, and was the reason that we progressed our elimination. So that's a great step forwards. So I was asked also to speak about the COVID and the impact of COVID on our program, and I'm just going to address very few questions and very quickly speak about how we've done with our national program. And this is only in one slide showing how we progressed from 2006 till current, and then the population-based screening and the impact of COVID and mitigation of consequences, the risk of severe COVID and HCV and benefits that can be derived from the pandemic. And we all know that lower and low middle income countries are the countries with the highest hosting the highest prevalence of hepatitis C, and Egypt was one of those. Egypt used to have a prevalence rate in 2008 in our demographic health survey of 10% viremia and 15% antibody positivity against hepatitis C. And by 2015, with our program progressing, it dropped down to 7% viremia of the population between ages 15 and 59, and with 10% antibody positivity. So as we can see here, that the lower middle income countries have the highest prevalence. Almost 41% of cases in the world with hepatitis C are residing in those countries. For children, the situation, I've been advocating for children for many years, and our earliest study with the Polaris Observatory with Homi Rezavi and his team for 21 countries showed almost 4 million, an estimated 4 million children with viremia, less than 19 years of age. But when we included all countries, 274 countries, with a model study, we found that the prevalence is almost around 3.25 million children less than the age of 18 years who are infected with hepatitis C. And those would require treatment, would require to be diagnosed and treated. Of course, the prevalence is incremental with age, so the younger age groups have a lower prevalence. As you go to the older age groups, the prevalence becomes higher, and it's highest in the group of adolescents between ages 15 and 19, where the high-risk behavior is. And also the prevalence is associated with the prevalence in the adult population, and of course with the prevalence in women in childbearing age, where there is transmission in some countries from mother to child. But there are countries like ours as well that have a high risk groups, like those receiving multiple transfusions, cancer chemotherapies, renal dialysis, among other groups. So this is our program and how we progressed. The National Committee for Control of Viral Hepatitis was developed in 2006, and we launched the first National Action Plan in 2008. And we introduced at that time, the pegylated interferon and ribavirin at a very low cost and we started opening specialized liver centers where we trained more than 1,000 physicians and nurses to treat patients with hepatitis C. And we connected those centers with a database system where all the centers were connected with a network. The patient's baseline data was all on the database. And from the central office, we could see which ones received treatment and how they received treatment and the outcome of the treatment, and whether they were cirrhotics or had advanced fibrosis or mild fibrosis. So we had all the data in the central office of the National Committee. During the period between 2006 and 2014, when we introduced the direct-acting antivirals, we treated 350,000 with pegylated interferon ribavirin, despite even a couple of revolutions in the country and total chaos at times, but we sustained the treatment, and the treatment centers were not touched during this period. In 2014, we negotiated the prices of the direct-acting antivirals to 1% of its global price, and we started treating patients with the brand DAAs. Of course, we had the great infrastructure with all those liver centers and trained physicians and nurses and IT personnel. And we had also our data set and database system and networking system. So the introduction was easy, but we, at the same time, developed an online registration system so everybody could register online, and then they get an appointment, they get a printout where they get an appointment to go to one of the centers to be assessed properly. They would only have a test for antibodies at that time and take the test with them. And then they go with a form with a special code and serial number. And everybody was registered on the system. And initially, we treated in the first 6 months only those with advanced fibrosis, because we knew that 50% of those who received interferon did not respond and would have, they were either non-responders to interferon or would have advanced fibrosis. So we anticipated more than 100,000 who are going to register. But we were surprised that in the first week, we had 500,000 people who registered to receive treatment, because many of those knew that they were hepatitis C positive, but they were not eligible for the interferon therapy. So they were eligible for DAAs, so they registered on the system to receive the DAAs. By 2016, we, of course, we made the headlines, the New York Times and many other journals because of our big program. And we started treating, after 6 months, everybody. We opened up for all fibrosis stages. By 2016, all this was fully state funded. It was supported by the government, and there was a real political will to move this program forwards and eliminate hepatitis. 2016, we introduced generic DAAs. We did not allow patency for any of the drugs, and the Egyptian company started manufacturing the generic DAAs. So then we could introduce and treat more patients and even bring down the price to even lower. Now the course, full course of treatment with soft daclatasvir, which has been the exclusive combination since 2016, is for around $40 to $45. So that's for 12 weeks course of treatment. And now we have also available the Epclusa and the Vosevi at a higher price, but for those who are not responding, the government is supporting their treatment. Then we started running out of, the program started by 2017 losing its momentum. The people, the number of registrations were very low. And as we can see from this graph, it's very small, but it was losing its momentum here. So we decided to start to do some screening. And early on, they started with screening 6 million people who were of high risk population groups. And then we had the presidential initiative in 2018 to screen the whole adult population. And that was very, very unique. We started in October 2018, and that initiative was called 100 Million Healthier Lives initiative, and it's a nationwide screening campaign for both adults and school children, as well as marginalized populations. We scaled up our treatment centers to 172 treatment centers distributed all over the 27 governorates in Egypt. We had 123 clinics dispensing treatment. But with the screening program, we managed in 6 months using the primary healthcare facilities, the government hospitals, mobile units, and even the youth facilities to screen 60 million adults in a period of 7 months, in addition to 9 million children in schools with the school screening program. That's just showing some of the activities in villages and how they were screening. And that's where we were screening at the highest prevalence rates in some of the governorates, particularly in the Delta region in Egypt, where the prevalence was much higher. This is how we had a live online system registering everyone, because they were testing at the testing sites. We had a physician, we had a nurse, we had a data entry clerk, and they were entering the data immediately with screening. They were testing, and we had the results of the test with a rapid test within 5 minutes. And at the same time, we had them weighed and measuring their heights, body mass index, and the blood pressure, as well as the blood glucose. So we were screening also for non-communicable disease. And that actually encouraged a lot of people to come on board. And I think that's one of the most successful elements, is integration with other diseases like the non-communicable disease. And this really was very successful, because everybody wants to make sure he doesn't have diabetes or has hypertension. They would like to see how much do they weigh and if they need to lose weight, etc. So that was really very, very successful to add on the NCDs, and that really encouraged people and removed the stigma of going to get tested for hepatitis C. So that was really successful, and it also allowed the Ministry of Health to draw a proper map, a health map for the future, knowing that the burden of diseases, people with potential hypertension, almost 10 million, with potential diabetes, over 2 million, and 19 million with obesity, and that's really huge. And I believe that the coming epidemic would be diabetes, coronary heart disease, and all the metabolic syndrome, including the fatty liver disease. So that's what we could see from the central office immediately once they enter on the system, on the tablet, the person who is positive. You can see it immediately live on our system. That's the map and the seroprevalence, and this paper was published, the screening and treatment program to eliminate hepatitis C in Egypt, in the New England Journal last year, showing all the details of the program and the prevalence rates in different governorates. And we had, of course, a prevalence higher in males than in the female population. In the planning phase, we had a lot of stakeholders, and I believe that one of the key successful elements for this program was the stakeholders' engagement. The whole country was mobilized. We had even the Ministry of Education, of Higher Education, the National Council of Childhood and Motherhood, and that's also for the school screening program, the Ministry of Information Technology, the Health Insurance Organization, the National Committee for Viral Hepatitis. We had the WHO representatives as external auditors, and that was really important for us. And there was a lot of community engagement with raising awareness. And I would say that one of our greatest allies in this program was the media. And I believe if you find an ally in the media, it will help you a lot in both the political advocacy and commitment, and as well in raising awareness among not only the public, but among the politicians and among the physicians and among many others. This is the screening program for children. I'm not going to go into the details for the interest of time, but we screened currently almost 9 million, and we are going to continue once the schools are opened again. And the prevalence rate in children is around 0.3 to 0.5%. The highest was 1% in one of the governorates. It's called Minya, and there is another one in Fayum one of the governorates were, and that was actually concordant with the high prevalence in the adult population. Those same governorates had the highest prevalence in the adult population. If we look at this, we'll find that the current treatment efforts, because we diagnosed almost more than 2 million people, and previously we had treated more than 1 million with DAAs before the mass screening program, and in addition to those treated with interference. So we treated more than 3 million people with, we say, a cure rate of more than 95% so far. So if we look at the current treatment efforts to date, they're projected to avert more than 250,000 HCV-related deaths by 2030, and with a 61% cumulative reduction and around 68% cumulative reduction by 2040. And the program in itself, if we look at the incremental cost effectiveness ratio for the HCV program in Egypt, it's calculated at around $751 per daily averted, less than 1 times the GDP per capita, which is $2,400. Of course, we're not accounting for the cost of advanced disease management, in addition to the social impact and stigma of the hepatitis, which is huge. So I believe that the factors contributing to our success was facing and identifying the problems, social and societal pressure for government funding, political will and support, and setting up an infrastructure for mass treatment, negotiating mass purchase prices, fully reimbursed or subsidized screening and treatment, and simplifying screening policies and evaluation and monitoring and evaluation. We also introduced the birth dose for hepatitis B since 2016, and the prevalence of hepatitis B in our children is less than 0.1% now, because we started vaccination at 2, 4, and 6 months since 1992. So recently as well, we started our triple elimination program for pregnant women, and I'm going to show a slide on this. So we need always to address our challenges and gaps, and I think with the COVID, there was a lot of task shifting. There was triage hospitals, some of the fever hospitals that were dedicated for treatment of hepatitis were shifted to treatment of COVID. So we had to shut down some of the facilities that were treating hepatitis. Albeit, I think that we've treated the majority of patients who were diagnosed, and lesser numbers are presenting to our centers now and are being diagnosed. But the diagnosis is still available, and testing facilities are still available, but a smaller number. And I'm going to show you how much we had to scale down or move down the numbers. The healthcare workers working in those fever hospitals are over 10,000 for COVID. 2,245 bed capacity for medical assessment. We have isolation hospitals in hostels. That was last year. We stopped doing isolation for the mild cases. We had many air ambulances, 1,500 vehicles, 4,000 ambulance staff, 1,200 logistics staff. Isolation and contact tracing, we had for this 18,350 healthcare workers. And for contacts, they tested over 1 million contacts, and we had 34 testing labs, and with a testing capacity of 20,000 tests per day. And definitely with the COVID, the pressure and the task shifting, the accessibility for services was reduced, and there was a reduction for service demand. So if we look at the state-sponsored treatment now, it dropped last May with the highest number of cases of COVID. It dropped to 38%. Now it's back by last September to 98%. So it drops and rises according to the waves of the COVID pandemic. And these are the number of units. They were 123. We had 123 units, and the total received treatment from the presidential initiative was over 1 million. Now working regularly after the post-COVID, only 24%, low work profile 72%, and stopped working completely 3.3%, and that number has risen in recent days. All screening programs for non-Egyptians, prisoners, pregnant women were temporarily halted last year. They are back again this year in 2021. all the programs are back again for screening and screening of pregnant women. School screening program temporarily stops as schools were closed. The HPV program still faces some difficulties due to shortages of medicine, especially at the peak of the pandemic with the lockdown because of the lack of the raw material. But now we are back on track. The shortage in research fundings, of course, and some of the clinical trials were withheld. And this is the number of the workforces that were dropped after the impact. The average number of healthcare workers in a unit before were 21, dropped to 15. Average number of workforce dropped from over 2,500 to 1,923 personnel. And the number of shifts dropped per unit from 1.29 shifts to 0.99 shifts. And if we look at the total visit numbers, they dropped dramatically, more than half. The employees per patient ratio, before they were 1 to 5, they became 1 to 3. Total patients numbers dropped from 4,364 to 2,223 and dropped even further in recent months. The medications were dispensed every 3 months instead of monthly before the COVID. However, we managed to implement the triple screening program according to the WHO recommendation for syphilis, HIV, and hepatitis B. And we had the 3 RDT tests with a cost of $1. And we screened over 885,000 pregnant women as of 20th June 2021. And we diagnosed more than 1,500 with hepatitis B, 104 with HIV, and 121 with syphilis. And I think I'll stop here. We have a lot of results and a lot of things to talk about, but I just wanted to highlight our program very briefly, and I'm happy to receive any questions. Thank you very much.
Thank you, ma'am. And I'd like to request you all to please open your videos for a few minutes so that we can have all together in a screen. Thank you very much. Okay. Just for a moment. And as you know, we're already running out of time. So I know Wang requested to go earlier because you have another engagement. So now I'd like to request Professor Ali. So have a short introduction, a short speech on today's activities. Please unmute you. Please unmute, sir.
Many thanks. I'd like to welcome Wang, President WHO, and Manal El-Sayed, renowned hepatitis activist of Egypt, and I'm very much impressed by his her activities and publications, and I'm very happy in the last elimination meeting in Amsterdam. She was the one to introduce me, virtually, of course. And I went through her multiple publications and activities, and particularly related to all this related with hepatitis C. And in our country, we have got the C is very less, but we made a study at Rohingya refugees and found a very dramatic high rate of hepatitis C among about more than 16%. And we are very much afraid because they are staying here for unlimited period, and we don't know when they will go or whether at all they will go or not. So though we have our population having less than 1%, but if they stay for a long time and if they finally enter to Bangladesh in very other ways, so it is a potential danger for us. So we should, though we have got the less amount of hepatitis in Bangladesh, we should be prepared also for increased incidence in our country infected by them. And I have written an article, and that article is also preparing for publication in the journal. And I like to thank Wang. We worked together with Charles Gould many years, and Wang is president, and she has got a tremendous role particularly many publications, particularly prevention of mother-to-child transmission. And we are also working, and I have written a brochure also in Bangla, as in English, and we are going to make it publicized, and with the involvement of gynecologists, hepatologists of these countries, and particularly involving the women folk in the universities and colleges to pass the message for prevention of that is the mother-to-child transmission of hepatitis B. And for birth dose, Professor Anis as well as Professor Fauque has already told, we are making advocacy in different levels for implementation of birth dose. And we have got a lot of problems. When I went to, during the writing of this article and brochure, I found a lot of problem in our country is existing for implementing birth dose. So I have outlined the barriers. I put it to the government, and government is also working. I hope it will be done one day. Next, I like to thank all my colleagues from Bangladesh, and they have rightly told the different scenario which they are facing in Bangladesh, and we are working together to overcome all those difficulties, particularly the control of hepatitis B and C, and everything has been problem arisen by the COVID pandemic. Even then, we should stand together and to control viral hepatitis so that the elimination target should be in the right path. What I think, some few things I put always emphasis from my long involvement in this, starting from 1999. I am in the field of this viral hepatitis issues in Bangladesh. One thing what I like to emphasize, that we should reach the that is grassroots activism. That is our 65% people in the rural areas. We must have to address them. We must have to pass the message of hepatitis B and C to them, because hepatitis B and C totally unknown to them. They know jaundice. They know other things like this. So we must have to pass our message of hepatitis, what is hepatitis, and how it is spread, and what it is prevention. So what is my motto is to decentralize all these hepatitis awareness campaigns to reach the common people at the grassroots level. Until and unless we have aware the 65% people in the rural areas, they are a little bit educationally backward, financially also disadvantaged. So we should address our all activities with them. Leaving them, we cannot fulfill our elimination target. Second thing, which I think now in this situation, I am emphasizing particularly micro-elimination. Micro-elimination is not a new concept. It has been started. Elimination started by European Association for the Study of Liver in 2017. But what I think that in this COVID era, we must think about this micro-elimination. We must have to think about the target high-risk populations. Suppose these patients are the high-risk group, because one patient may be there, one B may be there, and he or she may spread the whole family members. So patients, children, and other loads of the prisoners, hemophilics, thalassemia patients, thalassemia groups, all these target groups should be addressed first. And these target groups should be reached, and this is, it should be, they should be tested, they should be aware, and their condition should be treated, because treatment as prevention. Until and unless you have treated the patient load will not be reduced. So the treatment should be arranged, and because treatment should be regarded as the mode of prevention. more you will treat, more you will eliminate the patient. Because the patient population you must have to decrease. So how to treat? Treat needs investigations, and then needs follow-up, and reaching the people. Now the problem has arisen because of this COVID-19. How will you reach the peoples? Or the pupils cannot come to us. We cannot go to the people. That is the main. How can you treat the patients? And if you cannot treat, if you look into the COVID situation, we are not going. How can you do? Because hepatitis B and C will not sit. That COVID is controlled, and then something will be done. Hepatitis B and C will go on killing. Another thing is there. We know that a patient having infected with hepatitis B and C, if he or she is get infected with COVID, the situation of that patient becomes very much complicated, having high complication rate, even high mortality, than that of the common people who has got no hepatitis B or C. And if this is a early cirrhotic or cirrhotic patient get infected with COVID, everybody is imagining what will happen. If this is the scenario, we must be very cautious to pass the message to the hepatitis B and C affected individuals of the country that to take extreme precautions for prevention of COVID-19 protocol, so that they should not be infected. Second thing, reaching these people in this COVID-19, we must have to think of alternative way. We are thinking that using the social media, and then social media, Facebook, Twitter, Instagram, etc., and mainstream media, television and other things to aware the people. And you can pass the message through the information messages. And we are planning to arrange the webinars with the patients, with the social workers, with the students, so that the message can be passed. And we made already apps previously as No Hepatitis and Stay Well, but it has been downloaded now for revision according to the COVID status. So it will be uploaded very soon. And then hepatitis, No Hepatitis, Stay Well in Bangla, so that easily it can reach the common people. Another thing is we can continue, even then, we can continue our testing and vaccination program following strictly the COVID-19 protocols, so that the activists or those who go to the working should not be infected or by the COVID-19. Another thing, we are continuing this video consultation of the patients by different time, whatever the things comes, and giving instructions to those patients. Another thing, maintain of the drugs. You can give instruction to the people through your using all this media about the use of drugs, use of investigations, to help the patient during the urgent need of hepatitis problem. So where he or she will attend or sites. We are doing all these things. And finally, this I will say that for all those things, we must have to collaborate with the government, and all must continue our advocacy, so that the government should come forward for making the complete strategy for elimination, which they committed already. But you are understanding, everybody is understanding the situation of government is very much highly engaged with management of the everyday COVID pandemic situation, which is worsening in my country. And finally, of course, the treatment, as I told, treatment is the most important prevention of hepatitis B. So for treatment needs drugs, and drug should be available, should be less costly. Professor Salimur Rohman has already told that drug is available, but it is not up to the reach of the common people. So common people should get this drug. If they do not get the treatment, Even yes, we know very good things. The DAs has come, and the people are using these things, and people are getting benefit, getting cure. We have got a lot of patients, particularly under Zakat Fund. A lot of patients are getting treatment, and they are going cured. And so these things should be done, and government should also give some subsidy of these drugs, so that these common people, that is the disadvantaged or underprivileged people, should get this medicine. If they do not get medicine, this is, suppose the hepatitis B or C is a potential danger for each family. Suppose husband has got the hepatitis B. If it is not treated well, wife will get it. And if one wife will get it, 2 or 3 persons will get it. So first thing is this means together a treatment. This common people should get the treatment. We are running 2 kinds of fund. Fund is for common people. We use one kind of fund. Another one, I started Zakat Fund, and that Zakat Fund, we are providing free treatment to the hepatitis B and C patients. So my final advocacy will be 2 things. That is, we should make advocacy to the government for maintaining the path or coming to the path of elimination target to fulfill this, so that we can fulfill this 2030 goal. Another thing, with the stakeholders who are working together, even now there are multiple organizations have joined with this webinar. We can individually and combined, we can start different strategies for control of viral hepatitis in Bangladesh. Hope will one day viral hepatitis will be controlled in Bangladesh. Thank you, everybody. Thank you, distinguished participants from home and abroad, and you took your time by our invitation. Thank you, everybody.
Thank you, sir. Thank you, Professor Mohammed, sir, for your speech. Now, at the very end of this webinar, we like to request Wang for his concluding remark on today's webinar.
Great, thank you all. It's a real privilege to be here with you all today for this really amazing event for World Hepatitis Day. I want to thank Professor Ali, congratulate you on the recent award from the Coalition of Global Hepatitis Elimination. It's very well deserved. And really congratulate the National Liver Foundation of Bangladesh. You guys have been partners with the World Hepatitis Alliance for so long and have done really impressive and innovative work, utilizing all of the different campaigns and efforts we have. You guys have taken it to different levels that many people have never taken it. You've given people a lot of really great ideas about how to utilize, a lot of messaging and campaigning. So, of course, this year you guys have done a great job as well. Just looking at the presentation Zunai gave, that was, I think a lot of people might be borrowing some of your ideas. I love the idea of a clock for Hep Can't Wait. That's brilliant. We never thought about that. We'll have to do that. And the work that you've done has been so thorough. I mean, I just am so impressed how you've done awareness work. You've actually done testing, vaccination, treatment, and advocacy, and a patient conference. You are really so comprehensive, and I think you are really touching on all the really important areas for elimination. I think it's an urgent crisis. COVID has put a pause on a lot of our progress. We're very concerned about what it means for a lot of the services. There's been a lot of disruption. I really appreciate hearing all the emphasis on PMTCT and vaccinations. We're very worried that there's going to be a lot of babies who are born with hepatitis B because they were unable to get the vaccines during COVID. So we have made progress, but also COVID has stalled some of that. And just some background about myself. I'm the president of the Alliance, and I'm a primary care physician. I'm also somebody living with hepatitis B, probably infected either at birth or childhood from my grandparents who were actually healthcare workers. And I'm also a mother of 4, so the issue of primary, preventing mother-to-child transition is very near and dear to my heart. I feel very grateful that all 4 of my kids were able to get the Hep B vaccine within 12 hours of birth, and they got the HBIG. And I can't imagine what it would feel like, if I had passed it on to my children and I would have to worry about this, for the rest of their lives. So I just think this is something that we need to bring up to decision makers and researchers, because it's the babies can't speak for themselves. They need us to speak on behalf of them. So yeah, we have 9 more years until 2030, and so it really means we need to accelerate our progress. I think hearing the work that you've done, what Manal has done in Egypt, just really highlights the gaps and also what the successes are. So clearly, having national plans, having funded national plans, national awareness campaigns, those things are really, really important. Egypt has done a stellar job of that, and we need other countries to really step up. So I think we also just have to remind people this is such a big global health tragedy, right? We're talking 360 million people in the world with Hep B or Hep C. That's more than 10 times the number of people living with HIV. And yet we don't get as much attention or resources as many of those other conditions, including malaria and TB. I think a lot of what you guys have touched on was so important. We need to increase access. We have great tests, diagnostics, point of care testing is really important. The WHO just came out with their Hep C self-testing guidelines. And the more we can increase access to community members and individuals and do differentiated care, and I heard a number of you talking about this, we do really need, even as a doctor, I recognize the gaps here. The patients I see are only the patients who made it to me, right? There's so many patients and people who've never even made it to my office. And so we need to work on the community level and demedicalize care, right? Because a lot of times healthcare itself can be a barrier. And so, my main message is it's really important to partner with the community, with affected communities, with patients. We need to give voice to people living with hepatitis, because until people care about people with hepatitis, they're not going to prioritize it. And we see what's happened with COVID, right? COVID can affect anybody and everybody. And so countries are paying attention, and we need people to see that's the case about hepatitis. Hepatitis could affect anybody and everybody, and it could be your family member, it could be somebody your loved one, your spouse, your children, and that it needs to affect everybody. It's not just a small sphere of people living with hepatitis. So I congratulate you guys and continue the good work. Thanks for spreading this really important message and holding this campaign. This Wednesday, we really hope that we make a really big splash and a big voice about hepatitis, so that the whole world can hear about how important it is for us to focus on hepatitis and get us to elimination, right? If we all put in the effort now, by 2030, hopefully we won't be having this conversation, right? We will have done the good work, and we will have given the next generation a hepatitis-free future. So I think it's worth it, and it's our obligation, right, for all of us to do this at this time. So thank you all.
Thank you very much, Suan. And another thing is I'd like to congratulate you, because this is the first time the WHO also have the same theme of World Hepatitis Alliance. The hepatitis can't wait. So we are waiting for so long for this. And thank you and congratulations that they adopt this year the same slogans of World Hepatitis Alliance. And thank you, all of you. We are really pleased to have you, all of you, with us. And hopefully this webinar give us a good way of thought and do something in the future events. And thank you very much. Thanks for your time for Liver Foundation. Okay, thank you.
Thank you, everybody. Thank you, Swang.
Thank you very much.
Manal,
Thank you. Bye-bye.
Take care.
Rohman, Professor Shahinul Alam, Professor Anisur Rohman, Professor Fauque. Thank you, everybody. See you somewhere.
Yes, hopefully somewhere soon.
Manal, many thanks.